Today we're going to talk about experimental studies. Now, as we mentioned before, there are two different types of epidemiology. There's descriptive studies and analytic scientific studies. The studies we're going to be talking about today, experimental studies, fall into the analytic scientific forms of studies. They are meant to evaluate hypotheses for the causes of disease or to evaluate the success of programs, which is called program monitoring or program evaluation. Now, experimental studies assign participants into two groups, and this is what sets them apart from other studies. In these two groups, one group will receive the exposure of interest and the other will not. So think about when we are testing the effectiveness of a vaccine. One group gets the vaccine, the other group gets a placebo, and they do not get the vaccine. And then we compare the two groups to see if the vaccine is actually successful. Now, the defining feature of an experimental study is that the investigator does assign the exposure. Now, these are sometimes called clinical trials or randomized clinical trials, but be careful not to assume that all clinical trials are randomized because they're not. Now, an experimental study often begins with deciding, first of all, what are we looking at? So let's say that we're investigating a new HIV treatment. We would begin by first looking at the source population. So these are people who are eligible to be included in this study, which would include, let's say in the state of Florida, we're looking at a new HIV medication. So it would be everyone who is HIV positive in the state of Florida. So we would then assign the participants that we selected to be in either the treatment group or the comparison group. The treatment group would get the new medication, whereas the comparison group would either not get a medication or they would get their old medication or they would be given a placebo. Now, we would then study them for a certain amount of time and then compare the incidence of the disease after. So we would look to see, did the vaccine or treatment reduce the incidence of HIV in the group that had the treatment group, and how did that compare to the other group that was on their old medication or a different medication? Now, when we look at experimental studies, they often emulate laboratory experiments. So if you look at a lab experience in natural science, the experimenter can control the temperature, they can control the gravity, they can control pretty much everything about the experiment. And these experimental trials that we do, these clinical trials, they mimic that type of environment. So let's talk about the process, and we'll begin with what kind of research questions are actually useful for experimental studies. So let's compare the difference between experimental studies and when we would use them versus when we would use observational studies, those like the cohort and case control studies. In experimental studies, think of it as we are intervening as scientists. We are making choices ourselves. So the research questions often involve a treatment, a preventive measure, a cure. And when we have to do these studies, we have to make sure that what we're doing is actually feasible and is actually ethical. What that means is that if I'm trying to predict who might commit, say, gun violence, I can't ethically do that, right? That is not a feasible project or an ethical project. I can't assign someone to be a person who commits gun violence or a person who does not, right? But I can assign a vaccine to a group of people to see if that prevents a disease, or a placebo to someone else to see if the vaccine is more effective than the placebo. We also, in experimental studies, have to expect that there is going to be some effect. So the vaccine may not cure the disease, but it does at least mitigate the disease. In observational studies, these are ones that are more appropriate for things that aren't ethical to do in experimental studies. So we can watch groups of people over time to see what behaviors they develop. So for instance, thinking about the gun violence that I mentioned just a second ago, we can look at how the person's, based on factors that they come across in their life, and see what factors led to a person committing gun violence. But we didn't assign gun violence to the person, and that is the difference. Another ethical issue that comes up in experimental studies is this idea of equipoise. Now, I've got the definition there on the screen, but what this basically means is that once you realize that one treatment or cure is actually the one that is best, it is unethical to continue moving forward with the experiment. You should then stop the experiment and give everyone the cure. So for instance, let's say we're looking at HIV treatments again, and we're testing 3 different drugs to see which one is most effective on treating, preventing, and maybe even curing HIV. We study that and the 3 different drugs until we know for a fact that one drug is more effective than the other. As long as we don't know which drug is more effective, the experiment can continue. But the minute that we understand that one treatment is better than the other 2, we have to stop the experiment and provide the treatment to the other participants that aren't receiving the one that's better. Because if we allow the experiment to continue on after we realize one treatment is better than the other, we are bringing harm to the participants. Let's briefly talk about the types of experimental studies. So one of the most common types of experimental studies is a prevention trial. This is where we give some agent, so it could be a vaccine, it could be an intervention, whatever it is, to either healthy or high-risk individuals, and our purpose here is to prevent the occurrence of a disease. So I have a couple examples here. Does removing lead from contaminated soil reduce or prevent lead poisoning in high-risk children? Or do certain drugs lower the incidence of breast cancer in high-risk women? Now, these can be called a therapeutic clinical trial, and these are also where we may give an agent to a diseased individual to either treat or cure a disease. So this is probably the most common. Another one would be like the individual trial, and this is treatment allocated to individuals. Now, this would be something where we're comparing 2 different drugs or 3 different drugs among adults that are infected with a certain disease. So sticking with the HIV, this could be we have drug A, drug B, drug C, and we are testing to see which one is actually more effective on the individual. In the community trial, we give a treatment to an entire community. So this could be something like looking at how fluoride added to drinking water reduce the amount of tooth decay and cavities in a community. Now let's talk about what study populations are. When we start designing our studies, we really have to take into consideration who our population is. And the choice of a population really depends on the purpose of what we're doing. And when we design these studies, we have to really sit down and discover what our specific inclusion-exclusion criteria are. These are our eligibility criteria, and they're always based on things like our scientific logic, safety concerns, and practical considerations. Now, it can include people of interest, at risk of an outcome, or those who the intervention could be most effective. It can also include people with a likelihood of complying with the treatment and who are more likely to allow themselves to be followed for the total study period. Now, we may need to exclude certain people, such as those that the drug could be harmful to. Maybe they have an allergy to certain things, or they are at risk of another disease developing because of drug interactions. But overall, we try and include everyone that we can. So let's say that we're sticking with the HIV treatment. We could consider as part of our inclusion criteria, if we're looking at something to prevent the spread of HIV or someone from contracting HIV, we could include those who are at high risk of contracting HIV. We could also consider including those who have HIV to see if we can prevent the spread of HIV to others. We might also include exclusion criteria, such as individuals who are pregnant or who are not at risk for HIV. It would really depend on the study. When we are designing a study, we also have to think about how generalizable a finding might be to the population. So we really want to select a study population that we can then generalize our sample back to the larger population. So if, say, we're looking at the state of Florida, we would want a sample that is representative of the people who live in the state of Florida. But if we have too much inclusion and exclusion criteria, we're no longer as representative of the state of Florida, and our study loses generalizability. Okay, so when we start thinking about like who is going to be included, we might want to think about like what groups are we looking at? Are we including all humans? Are we including all men, all women? Are we including people who are at risk of a certain outcome? So here's kind of the hierarchy. It's the reference population, then the experimental source population, then the study population. Then once we get informed consent from all the people in the study population, we then divide them into the treatment and the comparison groups. Now let's talk about informed consent and enrollment procedures. So first, we talked about before in the ethics how you need to have the Institutional Review Board approve protocols before initiating any procedures. And this involves in submitting a bunch of paperwork, including our consent forms, how we're going to recruit people, and how we're going to determine how exposures are assigned. So remember, in this case, an exposure is a vaccine or a treatment. We also have to demonstrate to the IRB that we are making sure that people are safe, that people have a minimized risk of harm, that we are protecting their confidentiality, and so on. So before we can ever begin the process of assigning someone to a treatment or a control group, we have to get informed consent. Informed consent means we give clear explanations of the goals of the research and the methods that we're going to be using to test it. So we would tell people that we are going to provide you with a potential treatment for HIV, and this is what we expect the vaccine to do, and that there could be these potential side effects. We talk about the benefits of participating, such as this might potentially cure HIV, and that we will protect their confidentiality. So we would say we don't store your name on any documents, that is kept in a separate computer just so that we can contact you. And once we have that informed consent and then we enroll them, then we can begin to assign treatment. Now, the key way we want to assign treatment is through randomization. This means that every single person in the study has the exact same probability of receiving the treatment as anyone else. Now, some ways we could do this, we could just toss a coin. Every single person that comes up, we toss a coin, and group A is the treatment, group B is not, and there you go. We can also let the computer just generate a random order for people. Or we could let people self-select, or we could tell people show up on a different day of the week. However, some of these methods are not as reliable as others. We'll talk about these in a second. But randomization prevents biased group assignments. One of the ways it prevents biased group assignments is that it eliminates confounding factors. And we'll talk more about these a little bit later when we talk about bias. But when we randomize, we create two groups that are the same, except one group has the treatment and one group does not. Now, what do I mean by the same? Well, if we were to look at the people in the samples and compare them to each other, they should have like similar averages across things like their age and their race. So the treatment and comparison group characteristics should be balanced. So the exposed and unexposed group should have the same percentage of men and women, the same percentage of people who are this age, same percentage of people with the disability. Now, with randomization, this occurs for both known and unknown confounding factors. And so, as I said, we'll talk about confounding a little bit later, but think of it right now as a factor that leads to a misrepresentation of the association between our two variables of interest. Now, this only works if we have a big enough sample size, and it only works if the treatment assignment is not influenced by the investigator or by, as I mentioned on the last slide, factors that are not as reliable, such as allowing people to assign themselves by day of the week. So let's look at how the randomization might work. So we're looking at men in the United States who are between 40 and 84 who might be willing to take a low dose amount of aspirin to see if that actually reduces cardiovascular disease and death among men. So you can see that the size of the sample after randomization is about the same. The people getting the aspirin, there's 11,037 of them, and the people getting the placebo and not getting the aspirin, there's 11,034. But how do they actually look together? Well, here are the characteristics. If you notice, the people who are enrolled, they're the exact same age. Their average age is 53.2 years. They also have a very similar cholesterol level and an almost identical diastolic blood pressure. You can see that all the way down, they are pretty similar. So I would say that this randomizing was pretty successful at making sure that there's a balanced group and that they're very similar between them. Now let's talk about minimizing bias. When we randomize, that's what we're doing. We're trying to minimize bias. And one of the ways that we can minimize bias is through blinding. Now, blinding, which is also called masking, is a way of ensuring that participants and possibly even the study investigators have no idea whether or not a person in the experiment has been assigned to the treatment or to the placebo group. So first, there's a single blind study. This is where the people taking part in the experiment do not know whether or not they are receiving the treatment or the placebo. The next step up, which is probably the most common, is called the double-blind study. In this case, neither the participant nor the actual study investigator administering the treatment knows who is receiving the treatment. So let's talk about this one for just a second. In this case, the person who is receiving the treatment doesn't know what they're getting. But as I said, so does the investigator administering the treatment. So in this case, we might take a vaccine that we're going to use to treat HIV, and then one of their more common drugs that they are currently taking. They're just going to have a number written on them. The person administering it is not going to have any idea what that number means, and they're just going to give that person that number. And so the only person then who knows is the person who is overseeing the experiment overall, but they're not actually administering the treatment. Now, in a triple blind study, this takes it away from even that person overseeing the experiment. In this case, only the computer knows who received a treatment and who did not. So the participant doesn't know, the nurses or doctors providing the intervention and cure do not know, the person who set up the study, who is overseeing it overall, they don't know, only the computer knows, and no one finds out until after this study is over. Now, blinding is not always possible. There are certain things that you can't blind for. A person knows if they have had surgery. A person knows if they've had a pacemaker put inside of them. You can't blind those studies. But for most things, like for vaccines or treatments or cures, or think about the aspirin, we can actually blind those. Now, one of the ways that we blind a study is using a placebo. Now, this is where we provide a drug alternative. So thinking about, let's look at treating COVID. We might give the people in the treatment group a new drug to prevent or cure COVID. But in the control group, we're going to give them just saline solution, right? That we would just normally give to rehydrate a person in the hospital. And we would not tell either group what they were getting. They would not know whether they were getting the placebo or whether they were getting the treatment. Now, as I said, we can't always use placebos, and this is why we can't always mask, because, as I said, people know whether or not they've had surgery, they know what they're eating, they know if they have different medical devices put into their body. But we want to control for placebos because our minds are very powerful, and if we believe that we are healing, there has been some evidence to suggest that people in the placebo group can improve on their own because they're told that they will, and this is all from the power of suggestion. One of the other things that we need to do to minimize bias is to increase compliance. This is to ensure that people follow the study until the end. This means we have to have the groups as alike as possible on pretty much all the characteristics through randomization, but we have to have them as different as possible on exposure. So, for instance, we have to make sure that people are taking a pill every day. Now, deviations from the protocol can occur for many reasons. They could develop side effects, they could get sick, they could lose interest, it could take too long to follow up. So we want to make sure that whatever we're asking our respondents and participants to do is not so out of their way. It's not going to require them to do something that they will eventually just decide to stop doing it. So imagine going back to that placebo and aspirin study that we talked about a few slides ago. If the doctors required the person to take a pill every hour, how long before most people kind of dropped out? Now, non-compliance tends to make the treatment and comparison groups more alike. This means that we can't really detect differences between groups, and the only reason that we're comparing groups is so that we can see if differences exist. So we really want to have a good compliance. So remember, when I say it makes them more alike, this means it pushes bias towards the null, saying that there's no difference between groups. So going back to the Physicians' Health Study, we've already seen how they were randomized and very similar. Okay. Now let's talk about what they required for compliance. All of the participants were sent a supply of monthly calendar packs. They were also sent questionnaires about their compliance and the occurrence of health events. After 4 years in the study, almost all of them were still providing information on their illnesses. Now, there was non-compliance included, and so let's talk about that briefly. After the 4 years, a little over 14% of those in the placebo group had reported taking aspirin or similar drugs, and about the same amount of those in the aspirin group took less than half of the pills that they had been given. Do you think this may have impacted their results? Well, in order to determine that, we'd have to do some analysis. Now, I'm not going to go into analysis in depth here, but here's some things that we would do, and we will talk about a few of these things a little bit later in the semester. So first, we would look to see if the randomization even worked, and we've already seen from the table that it did, that the groups were very similar to each other. They were similar ages, similar blood pressure, similar rate of disease. We would then set up something called a 2x2 table, and you'll see one of these if in the next week or so. We would then, in that 2x2 table, determine if the confidence intervals or the incidence ratios in the treatment groups and comparison groups were similar. We would also then compare the risk ratios between the comparison groups and the treatment groups to see if the risk was similar for both groups. So, for instance, if we go back to the Physician's Health Study, looking at the aspirin versus the placebo, and we actually examine it, what we find is that those who took the aspirin had a 42% decreased risk of developing myocarditis than those who did not get that and got the placebo instead. So let's just sum up. Experimental studies, especially randomized controlled trials, can yield very rigorous results because randomization prevents confounding, and by blinding, using placebos, and encouraging compliance, we minimize bias. It is considered the gold standard of epidemiologic research, but we can't always use them. There are practical issues. They are very expensive. Compliance is very hard to get, and follow-up is also time-consuming. Consider a study that requires a participant to show up to your office every month to get a shot. You have to make sure that that person shows up. There are also ethical considerations. Remember, we talked about equipoise. The minute that we know that one treatment is better than another, we have to stop the experiment and give the treatment to everyone so that we're not bringing harm to our participants. Now, there are many methods that we use in epidemiology that are designed to mimic randomized controlled trials, so we don't always have to use these. Okay, let's stop here.